Good afternoon, everyone. At the outset, I would like to thank the organizing team and Dr. George sir for giving me this wonderful opportunity. For the next few minutes, I'll be talking on indications and a safer surgery system for GDD. Glaucoma, as we all know, is one of the leading cause of irreversible blindness, and of course, TRAP still remains a primary surgery of choice in most of the patients. However, GDD also plays a very major role in managing refractory glaucomas, not only as a secondary procedure. Of late, they are being used as a primary procedure too in managing lot of complicated glaucomas, infantile and developmental glaucomas. Ophthalmic surgery is an evolving one. Day by day, we are seeing lot of changes being made in ophthalmic surgical techniques. Likewise, in RD surgical technique also, there have been lot of refinements have been made over a period of 13 years. Going back to the timeline, first RD surgery was performed in 2011 and it was made commercially available in the Indian market in 2013. And initially we are doing RD with scleral or corneal patch track, and from 2016 we slowly started this technique of patchless RD surgery by creating a 4 mm long scleral tunnel. So this tunnel will prevent the tube exposure in the post-operative period, and from 2021 we started doing the supramid stenting, which is nothing but 3-0 nylon multifilament suture. It is used as an internal tube occlusion suture. So this will prevent the hypertony, which is most commonly seen with non-vault implants. Now, how to achieve optimum surgical outcome in GDD? I'll be sharing few tips which I'll be covering under 3 broad headings. I would like to emphasize here that pre-operative planning is very, very crucial before we take up any patient for GDD. I'll be sharing few clinical scenarios here. So first, this patient, a case of Goldenhar syndrome, you can see preauricular tags and limbal dermoid. He presented with microspirophakia and secondary angle closure glaucoma with a very high intraocular pressure and advanced glaucomatous cupping. Initially, he underwent YAC-PI and we planned for a quadruple technique, which is nothing but PPV, PPL, SFL and RD. Almost in the left eye it was uneventful, but right eye you can see a very big limbal dermoid sitting over 8 and 9 o'clock position. So initially we did a limbal dermoid excision and then we proceeded with the quadruple technique. And she is a middle-aged female, a case of eye syndrome with advanced glaucomatous cupping and high intraocular pressure with a significant nuclear sclerosis. So we wanted to do a combined phaco with RD implantation, and even though we are going to place a tube in the sulcus, it's very important to assess the corneal endothelium status using specular microscopy. And this child is a 7-year-old child, a case of neurofibromatosis. You can see a plexiform neurofibroma of the right eye with multiple caveolate spots. So he presented with multiple anterior segment pass and a developmental glaucoma with the advanced glaucomatous cupping. And we wanted to do a RD with a tube in the anterior chamber. And you can see a lot of pass is extensive pass in the superior quadrant. So meticulous gonioscopy and AIOC assessment of the superior quadrant, it helped us in placing the tube in the anterior chamber. And of course, we have to accept that glaucoma does not occur in isolation. It can be associated with lot of ocular anomalies as well as systemic anomalies also. Like this child, a case of phacomatosis pigmentovascularis, you can see nevus of Vota and extensive cutaneous pigmentation all over the body. So she presented with megalocornea and bilated childhood glaucoma, and we planned for a non-vault RD implantation in both the eye. However, when we did a B scan, we could see a increased choroidal thickness. So these children, they are a higher risk of developing choroidal complications with any invasive glaucoma surgeries. So we did a meticulous follow-up of this child in the post-operative period. Now moving on to intraoperative tips. So I'll be showing a step-wise video of how a perfect RD surgery should be done. This patient, a case of juvenile glaucoma, and you can see a fibrous bleb superiorly. He presented with high intraocular pressure and advanced glaucoma. So we took up this patient for a RD implantation. First, I am taking a corneal traction suture with 7-0 silk. Adequate exposure is very important since we are going to operate at a distance of 8 to 10 mm from the limbus. And exactly between 12 and 3 o'clock, I am just making a conjunctival dissection with adequate T-notch dissection and posterior relaxing cuts. Exactly at the midway between 12 and 3 o'clock, I am cutting the intramuscular septum. Step 2 is muscle separation. You have to handle the tissues very meticulously. First, a muscle hook is introduced beneath the superior rectus And then beneath the lateral rectus muscle, a gentle lateral traction is now created. And now a second muscle hook is introduced beneath the first one to clear away all the adhesions beneath the muscle. So this step ensures smooth placement of the lateral wing of the RDE device beneath the muscles. Now the RDE device is taken. Patency of the tube is cross-checked by irrigating saline with the 27 gauge needle. Thorough washing of the device is done. This is a supramed suture with a 3O nylon multifilament suture. And we usually practice a technique of double watertight occlusion suture with 6O vicryl. One should be placed over the supramed and other just in front of the supramed. Watertight tube occlusion is cross-checked by irrigating saline with 27 gauge needle. Now the RD plate is introduced beneath the superior rectus muscle first and then beneath the lateral rectus muscle. So you have done the T-nodes dissection well, then this is going to be a smooth one, otherwise you may have difficulty during this step. So once it is placed between the muscles, I am just moving it laterally to ensure that it is not struck in between muscle fibers. If it is going to get struck in between muscle fibers, it may lead to post-op diplopia, squinting and restriction of extraocular movements. A partial thickness T-node traction suture is taken for adequate exposure. Now I am fixing the plate using a 9-1 nylon non-absorbable suture. To prevent the posterior migration of the plate, the suture knots are brought into the fixation hole. Otherwise, this may lead to post-operative suture exposure. Similarly, the tube is also fixed to the sclera using a 9-1 nylon non-absorbable suture. This is to prevent the lateral movement of the tube. Now I am taking a second watertight tube occlusion. This should be just anterior to the supramed stenting. You can see a clear kinking of the tube. Again I am cross-checking the watertight tube occlusion. And you have to make sure all the suture knots should be towards the side of the tube. It should not be over the tube. If it is going to be over the tube, it may lead to suture exposure in the post-operative period. And if the suture is going to be under the tube, it may lead to tube exposure in the post-operative period. Just I am sharing a clinical photograph of how an RD surgery should not have been done in this patient. You can see the RD plate is just sitting in the superior quadrant. It is not in the superior temporal or superior nasal. And also the anterior ridge of the plate is almost 6 mm from the limbus, and also you can notice a long end of the tube in the anterior chamber. And here also the suture is almost over the tube. This has led to constant conjugal necrosis and erosion and ultimately the tube exposure in the post-operative period. And this patient also, due to improper plate fixation, she had a dynamic tube movement, and with the extraocular movements, the tube was almost rubbing the pupil. It is going beneath and coming out of the pupil. So she presented with intermittent episodes of iritis. So we have to take up this patient for tube trimming. So next comes the most crucial step, that is a 4 mm long scleral tunnel. So as I already mentioned, we routinely practice a technique of patchless RD surgery. So using a 23 gauge needle, the bevel length is about 2.8 to 3 mm long. We are just creating a 4 mm long scleral tunnel. So this will serve the purpose of the graft. A 4 mm mark is made from the limbus and 2 mm medial to the tube is made. A very minimal cautery is applied. A small groove is now made and a 23 gauge needle is introduced to create the tunnel. Exactly at 1 to 1.5 mm from the limbus, the needle is dipped into the anterior chamber. It should be parallel to the iris tissue. And also you have to ensure you are staying as close to the iris tissue. Stay away from the corneal endothelium. While taking the needle out also, you should be very gentle. Avoid unnecessary wriggling movements. Now the tube is draped over the cornea. A 2 mm mark is made on the tube. And the tube is cut with Vanna scissors to create a good bevel up. And I am using only a non-tooth forceps to guide the tube into the 4 mm long tunnel. Avoid using any tooth forceps, it may lead to microperforations in the tube. And also you can see the sinuous course of the tube. This will avoid the tube retraction in the post-operative period. I am just cross-checking the anterior ridge of the plate is at least 10 mm from the limbus. In few cases of developmental glaucoma, if you are going to notice pass, that is superior pass and the intended tube entry site, then always you have to plan for a modified tube entry. Here I have made a mark almost 4 mm medial to the tube and I made an AC entry into the tube. Now placement of supramid stenting in the subtenon space. Supramid suture of adequate length is cut and it is placed in the subtenon space. Avoid placing it in the subconjunctival space because it may lead to suture exposure in the immediate postoperative period. And finally, the conjunctiva is closed with AIOC2024. And the postoperative care includes adequate treatment with steroids, cycloplegics, and if you are noticing high IOP after 6 weeks, after autolysis of the tube occlusion suture, then you can plan for a supramid removal, but this should be done under strict aseptic precautions. Finally, a few points about Ahmed clear path. It is available in two sizes. One is model 350 and other is model 250. Almost the technique is same as that of RD. The two things we have to notice here is it has its own pre-threaded 4O polypropylene ripcord stenting, and also the suture points are positioned much anteriorly when compared to RD. ACP 350 technique is almost same, and for ACP 250 the suture is 2 to 3 mm of Prolene suture is left within the tube, and you can notice the much anterior placed fixation holes. Tube occlusion is done as we routinely do for RD implantation using 6/4 vicryl. You have to pinch the tube and you have to place in the intramuscular space created. So this technique is very much useful in patients with extensive conjunctival scarring, or in patients with post-scleral buckle, and patients with microphthalmos, or in patients with narrow palpebral aperture. Thank you all for the patient listening.
Thank you, Vijayalakshmi. Before I forget, the 3-0 multi-filament nylon which Dr. Vijayalakshmi was referring to is branded as Supralon from Orolab. And second thing is absolutely no harm in using the patch graft. What we want to stress is bury the tube at least 4 millimeter from the limbus in patient's own sclera to prevent tube exposures. And one small thing, Dr. Vijayalakshmi was also showing how she was routing the tube to a place which is farther away because of some anatomical impediments. So that was 4 millimeters. The tip is, you drape the tube over the cornea. Suppose it is 4 millimeter away, your incision is 4 millimeter away. If you can trim the tube 4 millimeter from the limbus, you get an optimal 2 millimeter length of tube in the anterior chamber.